Welcome everyone to this PEN Canada webinar for this month. It's about reducing barriers to care for people living with chronic pain and who use substance. Our main speakers today will be Therese Lin and then Dr. Annabelle Met, and then we have also Dr. Leonard Rip. And our moderator for today webinar will be Elvin Florid. And this webinar is sponsored by PEN Canada. So this is the LAN acknowledgement we display on the screen, but I will do my all LAN acknowledgement based on where I am today. And I am in Montreal, the unceded land or the stolen land of the Könenekahan people. And me as an uninvited newcomers to Canada, I am residing in this land, and all my interest is to contribute to the social justice and bridging barriers around discrimination to different people. This webinar is sponsored by the Partnership of Engaging People Patient in Chronic Pain Research and also the Institute of Musculoskeletal Health and Artists. And this is the housekeeping rules for this session. Like the chat will be monitored by our colleague Kimberly from the back scene. Then the question and answers will be monitored by me, and we'll be passing them to our moderator, Alvin. Then these are the closed caption will be displayed in your screen, and you can change them if you want so by pressing the CC that displays in the screens here if you don't want to be seeing the captions. The recording of this session today will be posted on PEN Canada website, the YouTube channel, and also we will be having them on the archive of PEN Canada and their webinars. We will pass the link to you as well. If you have any question or help needed, please contact us through educationpencanada.ca. The objective of today's session is describing the impact of stigma on people living with pain who use substance. And the speakers will be diving more about that, also explaining general approach to pain management for people who live and use substance, and also discussing ways for healthcare providers to reduce barriers to care for those populations. And by populations, we mean people with lived experience of chronic pain at both level, individual and system level. So from here, I will pass it on to Elvin. The mic is yours.
Thank you, Yasa. Hello, everybody, and welcome to today's webinar. As you heard before, today we'll be discussing on reducing barriers to care for people living with pain who use substances. My name is Alvin Florid, and I live in Edmonton, Alberta, and I'll be your moderator for today. And with us as presenters, we have three amazing people. We have Therese Lane, we have Dr. Annabelle Mead, and Dr. Lornette Rip. And they are physicians and people who live with pain. So Therese, how would you like to go first?
Hi, everyone, and welcome to our little webinar. My name is Therese Lane, and I live in Toronto, Ontario. I've lived with chronic pain for the better part of my life, and today I want to shed some light on the impact of stigma, especially for individuals like me who live with pain, have a history of intravenous substance use, bipolar disorder, homelessness, poverty, trauma, and abuse. These struggles aren't unique. They're experienced by many who confront stigma, judgment, bias, and discrimination within the healthcare system. These social determinants serve as formidable barriers to access an equitable and effective treatment. Over the years, I've learned that advocating for myself to receive treatment often becomes a battle. Most times, my illness becomes so advanced that it turns into an emergency. A poignant example occurred just 2 years ago when I developed pain in my groin and difficulty with walking, different from my usual pain. I mean, I've lived with pain all my life, and I usually know once I've been through my toolbox that my pain is different than what I experience every day. But getting that across has always been an issue. I contacted my family doctor, who I must add, I'm very fortunate to have. He recommended that I went to the emergency room for a faster diagnosis, and he sent a letter with me, phoned the ER. However, in the ER, my pain was dismissed and I was sent home without proper tests or consultation. This scenario repeated 4 more times until I could no longer walk. I was running a fever and I was becoming delirious with pain. This ordeal spanned well over 4 months, and by the time I was taken seriously enough to have blood work and x-rays, I developed osteomyelitis, and that caused a pathological fracture in my hip and my femur, and I ended up being admitted to the hospital, placed on intravenous antibiotics for 6 months, and it was only at that point did I receive relief for the pain. During this time, I was too ill and in too much pain to fight for my own rights, highlighting the fact that anyone with a history of substance use and or mental health problems faces these same battles when seeking pain treatment. Among my friends, I've witnessed the stark contrast between those with financial resources or good health plans at work and those without. While some access timely treatments like physiotherapy, chiropractic care, massage, and acupuncture, others are left waiting to have to go or go without. The lack of access to these treatments not only prolongs our recovery, but also affects our self-worth, our self-esteem, and self-confidence, leading to further depression, anxiety, guilt, and feelings of inadequacy. Additionally, it's essential to highlight that intravenous drug users in particular face even more judgment and stigma. The healthcare system often amplifies these prejudices. When seeking treatment for pain, IV drug users frequently encounter skepticism and discrimination, further compounding their challenges in accessing quality care. This additional layer of stigma exacerbates the struggle for validation and adequate pain management for individuals like myself. The difficulties faced by individuals who use substances, especially those with intravenous drug users, in seeking validation within the healthcare system are a critical aspect of my story. The prevalent stigma, stereotypes, communication barriers, and delayed diagnosis create a complex and often unjust experience for those already grappling with chronic pain and other challenges. Breaking down these barriers requires systemic changes, including destigmatization, improved education for healthcare providers, and a more compassionate approach to pain management that treats every patient as an individual deserving of dignity and respect. Through stories like mine, we can hope to drive change and create a health system that truly values every person's well-being. Thank you.
Thank you so much, Therese. It was beautiful hearing you share your experience with all this, and we are really hoping that in the future things will get better. And yeah, so we would like to hear from you now, Dr. Annabelle.
Hello, thank you. And thank you, Therese, for that very poignant story of medical illness on top of a chronic pain condition and in the setting of a history of substance use. It is a story that is really all too familiar to me from my experience over the past 20 years as an addiction medicine physician, working especially with women in women's recovery settings. So with that, I'm going to share my screen, and I'll have some slides to guide me through my 10-minute presentation that we have here. Okay. So I want to start with a bit of a look at stigma, which is no doubt the biggest contributor to barriers to accessing healthcare really across the board, but particularly in the setting of pain and substance use. Here are some of the terms and feelings that we associate with stigma. But what is stigma? One of the definitions that I like is that it's a negative attitude or idea that many people in society have about either a mental or a physical or a social feature of a person. So it really implies that there is a social disapproval of those things. Now, stigma is a major concern because they can lead to many negative consequences, in particular to discrimination, which is how someone treats you because of this stigma. People may be very embarrassed or ashamed of their substance use or mental health symptoms, knowing that others might judge them if they knew. So that's kind of like a self-stigma. We know that for people with chronic pain, often they feel like they should just be able to do better. They've often been told it's all in your head, or they believe that is what others think. And then, of course, there is much stigma associated with substance use in our society, and even particularly more so for people that are caregivers in our society. So parents, mothers, people who are pregnant. And we know that all of this in conjunction with the chronic pain syndrome represents some of the most stigmatized individuals. What can we as healthcare providers do about this? Well, I think the first thing that we can do is to acknowledge these feelings in our patients and validate them. And, within some other things that I'm going to talk about, that upfront can help reduce the stigma or that self-stigma. So let's take a look at what the literature tells us about barriers to accessing treatment. People who use substances report that and have pain are more likely to experience barriers to accessing any types of healthcare. And if people have a higher pain severity, they're more likely to unable to access addiction treatment if needed. 53% of people who use drugs reported being denied pain medication while in hospital in one study. So over half of people, and that does not surprise me at all. What happens when healthcare providers do deny pain medication? It often leads to the patient needing to go and self-treat using perhaps illicit drugs, or perhaps even leaving hospital and not getting that medical care that they need. Furthermore, when there is no clear physiological explanation for the pain, our healthcare providers feel very uncomfortable with that. In that setting, they feel less sympathy for patients, they're less inclined to help. In fact, they may even dislike these patients more. And often we find that if there isn't a really obvious reason for the pain up front, and this is often the case in chronic pain syndromes, then the healthcare providers can attribute lower pain levels to the patients. So in other words, there's this discrepancy between what the patient is reporting and feeling in terms of pain level and what the judgment coming from the healthcare provider as to how much pain they're really in. And this is certainly the case, particularly in chronic pain compared to acute pain. Clinicians are likely to underestimate and undertreat pain in people that additionally have substance use issues. So we know all this from the literature. Let's take a look at, from both the patient's perspective and the physician's perspective, or the healthcare provider's perspective, around what are these challenges to either accessing or receiving healthcare. So from the patient's perspective, there's often a fear of judgment, and this is really an extension of the stigma. They've often been treated differently in healthcare settings, often labelled as drug seeking when asking for help with pain management. Often there's a lack of trust in healthcare providers from previous bad experiences in hospital settings or previous settings where they've been receiving care from doctors or nurse practitioners or nurses. When we have this lack of trust in the system, it really impairs engaging and establishing and maintaining relationships with the people that are there to help you. Often patients have complex illness, making it difficult to, and I think Therese, you spoke about this, about self-advocating for yourself, trying to, when one is in pain and unwell, it is very hard to present very clearly the story of what your issues are. Often social supports are lacking, and often our patients have less than adequate pain coping skills in the substance using population. This is because many times people are used to using chemicals to manage distress and emotional disturbance. And then if they're trying not to use substances, then they haven't got those developed other mechanisms to help cope with the pain. As I just mentioned, impaired self-efficacy. When you're unwell and sick and in pain, it is hard to speak up for yourself and feel confident in doing that. And then finally, many of our patients with substance use disorders certainly have trauma histories, and I think many that have pain histories do have trauma histories. And again, this is all a complicated triad between pain, substance use, and trauma. So looking a bit more at that, trauma is often a precipitating event for the initiation of substance use, particularly so in women. These pictures and paintings that I have in my slide deck come from the residents of Heartwood Treatment Centre, which is a centre that I worked in some years ago that cared for women with mental health and substance use issues. And in that setting, at least 30% of the women that I cared for there were diagnosed with a significant pain disorder, and we had a weekly pain group there. So I thank those residents for sharing their artwork with us today. Why do people use drugs and alcohol in this setting? Well, often they're coping tools for managing the psychological symptoms of associated with trauma and past history of trauma. They can be very helpful in managing mood and anxiety, intrusive thoughts and unpleasant memories, such as associated with post-traumatic stress disorder. And substances can be used to counter the hyper-arousal and anxiety associated with that. Sometimes substances are used to help give an increased sense of control. Often people with trauma histories or substance use histories or pain histories are lacking in that sense of control over their own health care. And substances can help regain that, both in the care setting and within relationships. They can help one feel emotions. Sometimes there's a dulling of emotions and sensations in these settings. And importantly, sleep is very much associated with chronic pain. Sleep disturbance is associated with chronic pain and substance use. And therefore, substances can help with that. Now, it is important to say these substances can help for all of these things in the short term, but when used consistently or for a long period of time, it can be very counterproductive, very problematic as a long-term coping mechanism. Now, how about the challenges that we as healthcare providers face when trying to provide care to people with pain and substance use? Well, there's many things there. Not the least of which is that we are busy, and the way that our healthcare system is set up is that we have, 5 or 10 or maybe 15 minutes if you're lucky for an appointment. Patients in this setting require a lot of time. As noted, there's often complex medical conditions and sometimes, very emotionally charged interactions with our patients. We may fear worsening substance use if we're wanting to prescribe medications that might have the potential for misuse. Healthcare providers can be triggered by the distress that they see in their patients. These emotions and behaviors can be triggering for us. in order to manage this effectively, we really need to be confident in our own ability to manage our own reactions and emotions in this setting. Often there can be blurred boundaries. So for instance, as care providers, we have empathy and compassion for our patients. And sometimes that kind of can affect our ability to ensure that there are good boundaries and limits. For instance, wanting to prescribe extra medications for somebody when it might not be safe to do so. Many physicians admit that they're not confident about how to prescribe opioids safely if opioids are indicated, and how to detect substance misuse or emerging addiction in their patients, or even how to discuss these issues with their patients. Medical education is traditionally very lacking in this area, and it takes a lot of practice as a healthcare provider to acquire the skills to do a good job in this setting. We also there are very few guidelines for how to, what is best practice for managing pain and substance use in the same patient. And we have very few services that will look after both things in the one patient. So let's move on to how we can manage things, just an overarching look at how to manage pain and substance use disorders when they coexist in one person. And the best way to look at this is, what are our treatment goals and how can we address them? So I think I've mentioned already, sleep disturbance and mood irregularities are very common in both these conditions. So we know that if we don't correct sleep disturbance, chronic insufficient sleep will actually make pain conditions worse, can increase pain sensitivity. So we really need to be able to manage the pain and any associated mental health symptoms and any substance use issues all at the same time. We need to look at both non-pharmacological and pharmacological approaches. There's not one pill or one suite of, pharmacological treatments that are going to, do the trick. Otherwise, we wouldn't be in this situation. We do want to really limit unnecessary medications. When people have chronic pain, we often get into a situation of trying different medications because people respond differently to different things. So one medication may work for one, won't for another. So we usually go through this kind of hierarchy of trying something, and then if that's ineffective, try something else. As physicians and prescribers, we're very good at prescribing meds. We're not so good at stopping them or tapering off. So sometimes patients get into the situation of being on a whole host of medications. The problem with that is that every medication has side effects. So again, increases the complexity, and something that is it needs a good spotlight on. Similarly, we need to know if our patients are using any substances, alcohol, other types of substances, because that can interact with the medications that we prescribe and can also make pain syndromes worse, as Dr. Reeb's going to talk about in a moment. Some of the other overarching goals are to, of course, reduce suffering and distress in both realms and to restore functioning. Just a quick note on managing pain in the setting of opiate use disorder. So non-opioid pain management strategies will vary by diagnosis. So what I mean is we need a good diagnosis of the underlying pain condition, and then we can select the appropriate pain medication that will work for that. So we also need to consider non-opiate medications, of which we have quite a range of things that we can use, and also really importantly, the non-pharmacological options. Now, I think, Therese, you did mention that these non-pharmacological options, so we're thinking things of here like a chiropractor and physiotherapy and occupational therapy and massage and other trigger point injections. We've got a whole lot of things that can be helpful in some conditions, but there's barriers to accessing that care because they're not necessarily covered by our healthcare schemes. So again, this is stigmatization of people that can't afford some of these treatments. And finally, opiate agonist therapy. So this is medications like methadone and Suboxone. We're able to use are very useful for people that have active opiate use disorder, and they're very useful for treating pain. So we can use that medication to manage both problems. The tenet for me in looking after patients with substance use disorders or with pain, as well as with trauma, comes from our understanding of trauma-informed care. So trauma-informed care is a way of overarching treatment of people that really focuses on the recognition that trauma is there, but we don't need to ask about it. We can assume that most people have had some forms of trauma in their lives that might be contributing to how they're engaging in healthcare. So we need to focus firstly, when we first meet a patient, on safety, both safety in the physical environment and safety within the personal relationship that we're developing. So to that end, we need to, as practitioners, be transparent, predictable, authentic, and importantly, respect healthy boundaries with our patients. Many patients have had less than healthy boundaries in their previous relationships, and it can be very dangerous and feel unsafe to them if we are, say, too standoffish or too emotionally involved. We must always get informed consent for any treatments or procedures. And by that means a lot of making sure that our patients understand what we're offering, and that the patients have choice and control over the healthcare that they receive. Really, healing can only occur within the setting of a healthy, supportive, and trusting relationship that goes both ways. So this is my final slide, just to summarize reducing barriers. Number one, really paying attention to stigma and doing all that we can to recognize and reduce that stigma. Communication in a trauma-informed way. We need to ensure improved education for providers, both at the pre-med, medical school, and during residency, not just through lectures or talks like this, but actually one-to-one interaction with patients and learning. This is the way we learn the best, I think, from listening to the stories of our patients and providing care in these difficult situations and having good mentors. So for instance, Pain BC has a mentorship for providers like myself and Dr. Reeb to support other doctors in community around things like this. And finally, really trying to enable that all healthcare providers can provide compassionate, holistic approach to care for our patients. So thank you for that. I am going to stop sharing and I'm going to pass over to my friend and colleague, Dr. Reeb.
Great. Thanks so much, Annabelle. That was great. And thank you, Therese, for sharing your story. It's so impactful and helpful for everyone. So I'm going to share my screen and start in. So again, my name is Dr. Lonette Reeb. I'm a clinical associate professor at the University of British Columbia. And I've been an addiction medicine physician for 30 years, and I've worked within the pain clinic setting for 20 years, since I had a background in pain neurophysiology prior to medical school. I'd just like to share with you some more perspectives that deal with pain and addiction, again, from the perspective of understanding the background of what pain is and what are the limits of what we can and can't do and how to reduce stigma. So I'd like to start with a concept about pain itself, that pain is a primal and essential warning system within the body. It's just neurochemical signals that are rising up through the body and making their way to the brain. And it's not really pain till it hits the brain. The brain integrates this neurochemical signal and decides how threatening it is and will produce pain in order to change your behavior. That's the purpose of pain, is to change the behavior in you in order to help you survive on a biologic level. And this works brilliantly for acute pain, but not so great for chronic pain. We didn't evolve surviving a lot of chronic pain. So let's take the example of a dog running up and biting your leg. You have to be able to locate where on your body that is. So you have to intensely focus on that situation, where it is on your body, how deep is the bite, what does the dog look like, what's your past experience with dogs, what's your future fear about dogs, what's your emotional state, where's the dog owner. All these things have to be integrated instantaneously. And your fight or flight has to come up. The alarm system goes off in your body, and you have to fight, flight, or flee. So fight, flight, or freeze. And so let's say you kick the dog in the head and you run away. That's your adaptive strategy. Then you may have a memory of that dog, of the traumatic event, of who did or did not help you in that situation, of that owner that you might have told 14 times to leash their dog when you were on the same path. You know, all of this stuff gets integrated and plays into what the chronic pain experience might be. So there may be damage in the periphery, and those peripheral neurons, the nerves where the dog bit, may be sensitized, even though there's no dog anymore, but you may still be getting signals. Or the area in the spinal cord could expand its receptive field, its area that codes for that part of the body. So anything that touches that area suddenly feels painful. Or in the brain, the memory keeps perpetuating that pain feeling and experience. And every time you see a dog or think of a dog, you get pain. And all of these things combined with your mood, what medications you may be on, your past experience, and your future projection all go into your pain experience. So treating pain is then complex, and it needs to be biopsychosocial. It's not just treating the area of the body that was injured. If there's still a dog attached there or still some pathology we can do something locally about, absolutely, let's get in there and stop the pain generator. But if we can't, in many chronic pain situations, there is no more thing that we can do surgically or otherwise that helps the actual area where the trauma initially occurred. So we have to treat the pain at these different levels, at the spine, at the brain, and to help to calm down that signal so it isn't experienced as threatening as it was once. So what are the things that go into predisposition toward having a sensitized nervous system? We know that binge intoxication with alcohol or other drugs, and we'll get to opiates in a minute, trauma, especially early childhood trauma, that can include everything from physical abuse, sexual abuse, emotional abuse, and then injury, especially repeated injury over a lifetime. All of these things can sensitize your nervous system to have a lower pain threshold or to experience more pain when maybe a small or moderate pain is inflicted. All of those things actually change the nervous system so that it's more sensitive to pain and emotion. So it can lead to alcohol and other drug dependence. Anxiety disorders, depression, PTSD, and chronic pain disorders. So the top three can lead to the bottom three. And we see this all the time in clinic. People coming in with the bottom three things often have these front end loads with the top three things. It doesn't mean it's not treatable. It just means that it heightens the complexity. Dr. Apkarian is the world expert in using functional MRI imaging to look at the brain in pain. If you look at figure A, and that's the only one we're going to talk about today, he shows that someone who's been experiencing chronic pain, in this case it was someone with low back pain, eventually, after activation of the emotional areas and then some shutdown, the prefrontal cortex, the area at the front of the brain, because this is a brain kind of at an angle, so the area at the front of the brain here actually starts to shut down, and you can actually lose some of the neurons in there, some of the gray matter when you have chronic pain. And that area of the brain codes for executive functioning. So it's things like insight, motivation to get off the couch, empathy toward other people, problem solving, that can be blunted just the same as the addicted brain. Those areas of the brain can be affected in addiction. And when we have a patient with pain and addiction, often they have a lot of trouble with those kind of organizations. You can give them instruction on to do this or do that, and there's lack of follow through because the insight may not be there or the ability to do that may not be there. So we need to generate a lot more compassion and be able to give instruction in a very clear way and give a lot of support for that. The other thing is that when you are in chronic pain, you can shut down areas of the brain and the production of serotonin and norepinephrine, noradrenaline, adrenaline, these substances, and those feed down onto the spinal cord to block some of that neurochemical signal going north to the brain that gets integrated as a pain experience. So when you have pain, you often get mood changes, and then as your mood drops, more and more inability to cope with pain. So we need to co-treat all of these things, as Dr. Mead was saying. So serotonin and noradrenaline are part of the body's natural pain relief systems, and that's why we give medications that are antidepressants, which patients may say, I'm not depressed, what are you giving me this for? And that's because we know that those things actually are part of the pain relief system of the body. They help whether you're have depression or not. They can be helpful, even more helpful if there is a component of depression. I wanted to remind people that there's many, many other things aside from just pharmaceutical drugs or over-the-counter drugs or illicit drugs that can help with pain. So exercise, chiropractic, acupuncture, multidisciplinary rehab, psychological therapy, massage, yoga, mindfulness-based stress reduction, and Tai Chi. Even back in 2016 with Dr. Roger Chu did a systematic review, and he looked at the whole world literature in English on these topics to see how many studies exist that show it makes a significant impact on pain. So you can see that movement, exercise, activity is number one on that list. So that's why doctors often prescribe exercise and these other things. Some of these things, as we mentioned, are difficult if you have financial constraints, which with WorkSafe BC to doctors around the province, we've given about 43 lectures over the last 4 years or so on ways to help your patients get things like this, even when they don't normally have access to it. I also wanted to point out that not all medications work for all pain conditions, which is something that Dr. Mead alluded to. She was saying that we try to find out what kind of pain the person has and what it's from before we make a decision about what medicines to use. So you can see here 8 different categories of medications, and then the things across the top. LBP is low back pain, OA is osteoarthritis, and FM is fibromyalgia, and then neuropathic pain or nerve stimulated pain. I mean, all pain involves some nerves, but this is where the nerve itself may be damaged, not just signaling. So we know from these conditions that, for example, for neuropathic pain, that acetaminophen, which is Tylenol, non-steroidal anti-inflammatories like ibuprofen, diclofenac, Motrin, these things don't help so much for neuropathic pain, neither do muscle relaxants. So we shouldn't be using them for those. And if we look down the list, if you look at opioids, there's really question if it helps at all for low back pain. Even osteoarthritic pain, there's now a lot of question whether it can be effective. And for neuropathic pain, there was a recent Cochrane review, which is one of our world's best review of literature or studies on this topic, has shown things like oxycodone are not helpful for neuropathic pain. So we try not to use them for that. It's very confusing for the patient because many patients feel, especially who are opiate experienced as their drug of choice, that opioids, the morphine family of drugs, is the only real painkiller. And so we have to talk about that because we don't really have things that can kill pain, only medications that can reduce pain a little bit. About 2 points, 3 points on a 10-point scale is considered good pain relief. So trying to get complete pain relief is not really the ticket. Even when we talk about opioids for chronic non-cancer pain, the average pain reduction is 20 to 30%, but only 1 in 7 to 11 people get that level of relief. Most will respond by about 50 milligram equivalent of morphine if you convert whatever opiate they're on to a morphine equivalent. And our guidelines say we can go up to about 90 milligrams as a trial, because the vast majority of people will respond by 90 milligrams of morphine. If they don't, usually that's not the right category of medication to relieve the type of pain that they have. But that can be very confusing for patients. The non-responders need to be taken off right away. Now, when people are sedated on a medication, they can also kind of have an altered experience of pain, but we don't want sedation. It has to not only relieve pain, but increase function. If you just feel better but stay on the couch, the doctor's not going to want to keep prescribing because that didn't do the goal, which is functional restoration. It's a fantasy that endless dose escalations will provide further relief of pain. Otherwise, you just chase people's tolerance and something called opiate-induced pain sensitivity or opiate-induced hyperalgesia. So I'll talk about this in a sec. So we know from all the media reports and friends and family and coworkers and patients that we have that too much opiate medication or street opiate use can lead to death. You can have overdose that's non-fatal. It can add to sleep apnea, testosterone suppression, heart attacks, myocardial infarction, or motor vehicle accidents. Also, the whole issue of addiction, obviously. And all of these things, the higher the dose, the higher the risk of developing these things. And this can be why doctors may want to rein in the prescribing because they don't want to add to people suffering in these other ways. The other situation I want to discuss more about is how opiates can cause pain itself. So we give opiate treatment and you get cellular changes where the receptor gets insensitive. And that's classic pharmacological tolerance. That's where the person doesn't feel the drug anymore because their receptor's not sensitive. But there's about 21 different things that happen in the nervous system when you take an opiate over time that make the body more pain sensitive. First of all, you suppress your natural endorphins and enkephalins. Your body thinks, I got a lot floating around in the bloodstream. Why do I need to make more? So you're not making your own painkillers very well. The other thing that starts to happen is that you start to sensitize peripheral neurons, the ganglion, different receptors in the ganglion leading up to the spine. The spine itself, different neurons and different receptors can change with opiate exposure, and areas of the brain that code for pain can get altered so that you actually get more and more sensitive to pain the higher the opiate dose. And there's been very clear studies on this using cold pressure tests where you dunk someone's arm in a vat of ice water or you put a heat lamp on them. And we know the higher the opiate dose, the more pain sensitive people are. It's counterintuitive. For the acute pain situation, if you just break your leg and you have to go on a medication immediately, that's not the case. But very quickly, people develop these changes in the nervous system. So that's why we try to use as little opiates as possible and to get people off as soon as possible. But both of those things, opiate-induced hyperalgesia and pharmacological tolerance, leads to what looks like tolerance, needing more because it's not working. So doctors were initially, in my day, when I was in medical school, we were trained just to increase the dose back up. It doesn't matter, just go higher and higher. So we ended up with patients on hundreds or thousands of milligrams of morphine equivalent. Now we try not to do that. And that's because we don't want to make their pain syndrome worse in the long run. So there may be a sweet spot where they get a lot of pain relief, but not too much hyperalgesia. So we try to find where that is. Then there's withdrawal pain. Opiates, even for people who didn't have a pain disorder to start with, because of these changes in the nervous system, if you stop the opiate abruptly, you can unmask the hyperalgesia and produce pain. You can also release adrenaline-like substances because morphine and its family of drugs suppress adrenaline. It makes people feel calm, and that's lots of the reasons people use these substances when they're having trauma and other things. But that quick release of noradrenaline, if you stop fast, can cause neuroinflammation and activate the immune system and circulate inflammatory mediators in the body and cause more pain. So you get not only generalized aches and pains and withdrawal, but you can actually get pain at your injury sites. Now, I found, looking at my patients who stopped abruptly, sometimes even old injury sites that were completely pain-free before they started an opiate could hurt again. And we call this phenomenon a withdrawal-associated injury site pain. And we did a study that got published in the journal Pain, where we accessed patients who were in pain clinics or who were accessing research for people who were using substances. And we found people who had had a previous injury that was healed and completely pain-free before they started opiates for another reason, either for addiction or another injury, but during withdrawal had pain at that original injury site. And people scored their pain usually about 8 out of 10 compared to the original injury being 10 out of 10. And they said that it kind of activated their use of opiates again. So we were very interested in that. Now, what did the people say about that? So this is, remember, an injury site that's usually pain-free, and that pain usually goes away after withdrawal within 2 weeks. About 1 in 5 people, it can last over a month. So people said things like, I was pounding my legs, old injury sites are horrendous. The sensitivity to touch was increased. God, it felt just like it did when it was healing, when it was broken. There's also not just physical pain, but also anxiety from it too, like PTSD. I had one of the men I interviewed was very experienced with heroin, had gotten himself off and was drug-free for a number of years, was working as a construction worker, jaywalked, got hit by a truck, sucked underneath, fractures, about 16 breaks each leg, went through rehab, had some opiates, but got off, was completely drug-free, pain-free, back to work because he was young and healthy and amazing. But heroin called his name. He was clear for addiction reasons, not because he was in pain. But this time when he used and tried to withdraw, he said it was just like being back underneath the truck. He said it was like hot molten lava being poured across his legs, and he remembered the trauma of the event. So for the 2 to 3 weeks that it took for this to disappear, he would have to crawl to the bathroom on his hands and knees because the pain was so bad in his lower legs. And he re-experienced the trauma over and over again. So this kind of withdrawal, fast withdrawal, can produce trauma symptoms and produce pain. But once he could get through the withdrawal completely, he could walk normally and he didn't have PTSD, nightmares, etc. So we went on then to look at how frequently this occurs in injection drug users who are using opioids. So we did a large study looking at over 600 people. We found 276 people who inject drugs daily, who had a previous injury that was previously pain-free. And we found about 1 in 3 of them had this WISP, the withdrawal-associated injury site pain, that would later vanish if they got through withdrawal. And over 40% of them said WISP caused them to relapse or use more opiates. So you can see how this may be a hidden driver in the opiate epidemic, and no one's talking about it except us now. Things that helped WISP and the opiate-induced hyperalgesia that's been known in research and in our studies was gabapentin, anti-inflammatories, opiate rotation, lowering, or elimination. And so this may be why your healthcare provider may ask you to come down or off your opiate medication when you think that's the last thing I need, because I know every time I chew my medicine or snort it or inject it, I get pain relief. And the background medicine doesn't seem to be helping. And that's because you're hyperalgesic and you're just lifting yourself up above your hyperalgesia temporarily when you use a short-acting med. And so that's not good long-term planning, and you just prime your nervous system. So all this information takes time to communicate with patients. Many doctors don't even know about it. So it can be this situation where the doctor and the patient seem to be on a very different page. So we need to co-manage substance use disorder and pain. When substance use disorders are active, pain is much harder to treat due to dysregulation of all the pathways involved with mood, pain, sleep, and behavioral reinforcement, things that make you do the thing again to get relief. We must co-manage pain and addiction issues, and we usually in the pain world say no take-home doses of opiates if you have any active substance use disorder. The provision of safe or safer supply has really changed that. But it may not be the best way to manage everybody when people are out of control with their use, because then they can ramp up their own sensitivity. We must focus on non-pharmacological and non-opioid treatments. And when it comes to somebody who has pain in an active opiate use disorder, or OUD, we want to convert to opiate agonist treatment, or OAT, with buprenorphine, methadone, or slow-release oral morphine to stabilize. You want them on a long-acting oral medication, not a short-acting injectable if possible. Buprenorphine has the same or better pain-relieving effect as morphine. It's actually 16 times more potent than morphine. There's no evidence that adding a second opioid to methadone, buprenorphine, or slow-release oral morphine is going to help their chronic non-cancer pain in the long run. If they just have an acute injury like a break, you can do it. But in the long run, it's maladaptive and just worsens their hyperalgesia. So I see lots of patients who come in who are on, let's say, they say they take methadone for their addiction, but they take hydromorphone for their back pain, and they take oxycodone for their headache pain. This makes no sense pharmacologically and is likely driving their pain and addiction. But the lived experience of the patient is they get temporary relief when they take the short acting. And that's totally true, temporarily, but it's not a good long-term management strategy. It may worsen things in the long run. So for severe acute pain, when OAT at high potency when they're on OAT, you can use a high potency short acting opiate just temporarily and have a taper structure. So we need always to stress harm reduction and safety, like medication review, daily witnessed ingestion, callbacks for pill counts, bubble packing, safe storage, patch return to pharmacy, overnight oximetry, and naltrexone. All things we need to go over with the patients and help them with. Everybody who's on an opiate for pain or addiction should be on naltrexone. And I want to kind of end with this study that was looking at the experience of chronic severe pain in patients undergoing methadone maintenance treatment. They interviewed in depth 12 patients who were on methadone and scored their pain still as 5 or more out of 10 for chronic pain. Now, these patients might be hyperalgesic from the methadone, or they could have other things going on. But the patients felt that their concerns were not listened to, often dismissed, and they often felt quite alone. This led to social isolation, increased illicit drug use, and role failure, either at work or at home. They didn't feel like they were fulfilling the roles that they wanted to. Treatment approaches should emphasize emotional support, negotiation of explanatory models, and emphasis on the social sequelae of pain. So I'd just like to finish off with a quote from that study. One of the patients said, "What I want to feel is that the doctor is working with me. That means they're involved with you, they care, they want to see you get better." And I think we need to walk beside our patients as healthcare providers and help both hear from them and educate them and work together to find solutions that will work for them. It needs to be collaborative. So thank you very much for this section of the talk. I'm going to stop sharing my slides.
Okay. Thank you all so much for such an amazing presentations actually on reducing barriers to care for people living with pain who use substances. Thank you, Therese, for sharing your experience with us. We appreciate it's really brave of you to take us along, share your journey with us. Thank you, Dr. Annabelle and Dr. Lonette, for such presentations. I feel like there was so much to take in, but I am glad I was a part of this. And we have a few minutes to take a few questions. So the first question, these questions will not be directed at anybody in particular. So please feel free to answer the questions if you want to. I remember Dr. Annabelle talk when she was talking about the challenges to healthcare practitioners. One of the first things she talked about was busy, not enough time. So do you think if healthcare providers devote enough time in a standard office visit to do a complete pain assessment with their patients, like talk about pain, mood, stress, and all of that, and also review the non-pharmacological and pharmacological options of pain management, or properly assess a patient's risk of addiction, do you think that will help combat stigma and reduce barriers to care and substance use?
Yes, but as you've articulated, there's a lot of things in there that need to be done, and I hazard a guess that usually would take about an hour to do that. So there's different ways of doing that. You can book a whole hour and dedicate that time to that full assessment. You can do it in pieces, but that's, coming and going a bit. But the best way to manage this situation is to have a team of people to work with. It's very hard as just a solo practitioner, as one person, having to do all of that. So it kind of depends on the setting where you work, but that time must be dedicated to that. And you have to have that, even before doing all that, you have to have time dedicated just for getting to know each other, just for establishing that trusting relationship up front, because without that, we know the rest of it doesn't necessarily go as well as it could. Yeah.
Thank you so much for that.
I'd just like to share, just so patients have a little bit of idea about the barrier doctors have. If some other healthcare provider that year has billed for a full history and physical in the community, you can't bill for a whole year for that. So if you book an hour, you only get paid for the 10 minutes, So that's one of the pressures doctors have. Or if they booked a full physical, yeah. So anyway, it can be it's one reason to try to stick with one person to carry everything through, so that they know how you respond to drugs, if something doesn't work, come back to the same person. Don't just say, oh, they didn't know what they were talking about, I'm going to go to somebody else, because then they can't systematically work through things. It takes a long time. Even if we have studies that say this drug works or this thing works, for that individual, it may or may not work. We need to see how it works for that person. So these take a long time, like Annabelle said, and it's best if there is a team, but not every doctor has privilege to work in a team or nurse practitioner.
That was those were beautiful responses. And before we go to the next question, I just want to quickly read a comment in the chat from Lynn. She says, that was an incredible talk. Thank you. So thank you again, speakers. So our next question is, I know with opioids, it's, most times that is the first option we have. And we tend to try different ones before we finally settle on the one that helps. So in the case of a patient who finally finds a medication that helps for their pain, not because they want to abuse or overuse, but that is what works for them. So do you think a change to opioid prescribing standard can have a damaging impact on the treatment of chronic pain in that, a case like that?
Well, for chronic pain, we don't usually look at which opiate is being used, but the morphine equivalent. So we convert everything to morphine, and that's more what we look at. But we do know that some routes of application are much more addictive than other routes. So patches tend to have a low addiction and abuse potential. And whereas if you chew or snort a medication, it's a higher addiction potential. Or if it's an injectable medication, it's an even higher addiction potential if it's an opiate. So we try to move people. So it's both the route and the way they're dosing and the morphine equivalent. There's a whole bunch of different things we look at. Yeah. And the person's lived experience, like if you drink a 26er of vodka, that's going to give you more pain relief than 13 ounces of vodka, like a Mickey, or than just one beer. But it doesn't mean that drinking a 26er every day is actually a good way to manage your pain. It doesn't make you very functional, and it can be problematic. But the person's lived experience is, I need a 26er to get out of pain. So, we have to work with each other to try to see, okay, what is it you're trying to get to? How can we help you? And how can we balance these things?
Thank you so much, Dr. Lonette. Now, I'm also learning, so thank you so much for that answer. I don't know if we have enough time, but there is one more question. And
Therese has a hand.
Yeah, Therese.
Yeah, I just wanted to say that when it came to treating my pain, the best and safest option for me was to be on a methadone maintenance program. And I'm fine with that. I'm on a very low dose now. I seem to have like a baseline. I don't seem to be able to go any lower.
That's very common.
Yeah, but it's fine. It takes the edge off, and I have quite a while I accepted that, I was going to be living with pain. I was never going to be pain-free, but through exercise and a doctor that listened to me and heard me made all the difference. And I still have to abide by the rules of methadone. I still have to be monitored in the pharmacy once a week. I do get my carries. I take methadone 3 times a day as opposed to 1 drink. And I'm all right with that. Yeah, I don't usually need anything else. Yeah.
That's a great example. Thank you.
Mm-hmm.
Thank you, Therese. So one more question, because we are already out of time. One of the options we find ourselves being, asked to try is the non-pharmacological options. And we all know the challenges that come with that, funding. And sometimes you could be fortunate to have funding through other health benefits, but you do not, in your community, you do not have experts who are knowledgeable and have the skills to work with people with chronic pain. So do you think there is a need to train more experts in this domain? I think there is a need for that, because you could have the funding, but they haven't worked with people with chronic pain, and it's tough.
Yeah, I think there are experts out there, but it's actually hard to find out who is and what people's training is. I know in British Columbia, they are setting up some government-funded pain clinics now, and there are pain clinics that are private pain clinics that offer a lot of services that are covered by our medical services plan. But you really need to to be able to navigate this and to find these services, and that's where certainly Pain BC comes in handy as a repository of information around this. I can't really speak to the other provinces.
Yeah, it's kind of like this information is for the privileged few. Unless you know somebody who knows somebody, you don't know about some of the treatments that are available. And then there's the long waiting lists to get into them. So that in itself is daunting and off-putting.
One of the things we've been encouraging doctors to try is you can bill a group visit. So they could bring in all their patients that have chronic pain and bring in a physiotherapist for that session, or an occupational therapist or a psychologist to do a session or a series of sessions. And you can sit in the room and do your paperwork, and you can bill for that and then share the profit from those visits with the practitioner that you brought in, so then you don't lose money, but because you've paid your office staff, but you are able to expose people to things that normally they couldn't afford. So that's one of the things we teach through WorkSafe BC in the province in order to use the medical system. If someone is actually an injured worker through WorkSafe BC, there's lots of programming that is available, pain and medication management programs and concurrent care programs for pain, addiction, mental health now that exist. But if they're not an injured worker and they need to access through MSP, these are creative solutions for their nurse practitioner or family doctor to do.
One thing I found is that if you have mental illness and pain, one doesn't know about the other. And I know for the Center for Addiction and Mental Health, if you have pain, they don't know how to treat it. And vice versa. Yeah.
There's always
Thank you, everyone. Yeah. Thank you. Thank you, Therese. Thank you, Lynette. Thank you, Annabella. And thank you, Alvin, for the wonderful moderation. And thank you, everyone, as participant. It was a wonderful webinar today. It was very formative. So thank you, everyone. And before we end, this webinar is recorded as we earlier shared, and is available in Pain Canada YouTube channel. And if you have any question about this webinar in the future, please feel free to contact us in education@painbc.ca. Also, my colleague Kimberly already posted the feedback survey on the chat. Please feel free to just take 1 minute of your time and fill that survey. It will be very helpful for us just to improve things in the future, and also hear feedback from you all. Thank you very much and have a wonderful day. Bye, everyone.